This presentation is on the long-term adaptations of the cardiovascular system in response to repeated exercise/training. This is presented by Libby and Claudia Chrappah. The introduction consists of anatomy of the cardiovascular system and training principles. The cardiovascular system transports blood around the body through a closed network of blood vessels using the heart as a pump. There are three types of blood vessels. Arteries transport oxygenated blood away from the heart. Veins transport deoxygenated blood towards the heart. And capillaries connect both arteries and veins to enable an exchange of oxygen, nutrients, and waste products. Arteries possess thick walls as they are subject to high pressure when receiving blood pumped around the heart's ventricles. The arteries have three layers, which are also known as tunics. The inner tunic is a smooth surface which allows blood to flow easily. The middle tunic is the thickest layer made up of smooth involuntary muscle. The outer tunic made up of supportive connective tissues. The vessels are allowed to stretch due to the elastic tissue between the layers. This tissue also allows them to return to their original size. As the arteries become smaller, the amount of elastic tissue decreases. The structure of the veins is identical to the arteries. However, the middle tunic is relatively thinner. Veins also have less elastic tissue between the layers. The following diagram shows the inner tunic, the middle tunic, and the outer tunic, also showing the flow of deoxygenated blood through the veins and oxygenated blood through the arteries, connected by a capillary network transporting nutrients, waste products, and oxygen. There are three layers of tissue to the heart. Pericardium, the outer layer of the heart, reduces friction as the heart moves during its beating due to its double-layered cavity containing pericardial fluid. Myocardium, the middle layer, is a strong tissue that makes up the bulk of the heart. Endocardium, the inner layer, lines cavities and blood vessels. This image displays the major veins and arteries that are connected to the heart. They all aid in blood flow. As mentioned before, the superior vena cava and inferior vena cava. The flow of blood around the body is divided into two circulatory systems. Pulmonary circulation is deoxygenated blood that enters the right atrium via the superior and inferior vena cava. This blood then enters the right ventricle through the tricuspid valve. This is due to an increase in pressure in the right atrium due to the filling of blood. The right atrium transports blood into the lungs via the right and left pulmonary arteries. This is where gaseous exchange occurs. This oxygenated blood then returns to the left atrium via the pulmonary veins. Systemic circulation is when oxygenated blood then enters the left ventricle via the mitral valve. The blood is then transported to the organs in the body via the aorta. The blood that is now depleted of oxygen returns to the right atrium via the superior and inferior vena cava, as mentioned before on the diagram. Following the anatomy of the heart is the training principles. The magnitude of the adaptations of the cardiovascular system depend on the type of training principle applied. The three principles of training are overload, specificity, and reversibility. Overload is when a system or tissue is trained beyond its capabilities, so then adaptation has to occur from this system or tissue to cope. Overload consists of different aspects such as intensity, duration, and frequency of exercise. Reversibility is the term used to describe the loss of these gains if overload is removed. Specificity refers to how the type of training applied affects different specific aspects of the human body and its function, i.e. muscle fibers and lactate threshold. It also can refer to specific adaptations in the muscle as a result of training. For example, endurance exercise results in primary adaptations such as increase in the amount of capillaries and mitochondria. In contrast to this, if a muscle is subject to heavy resistance training, then contractile protein increase in the main primary adaptation attained, but the densities of mitochondria and the capillaries decrease. This response to different types of training show that different training methods can interfere with the adaptations of the others.
This discussion will be on measurement of cardiovascular variables, detraining, and the influence of age and sex. Measurement of cardiovascular variables. This consists of stroke volume, heart rate, maximal oxygen consumption, and blood pressure. Stroke volume. This is measured using Doppler echocardiography. This is a non-invasive measurement of an aortic cross-sectional area and time velocity integral of the blood flow in the ascending aorta. Heart rate. This is often obtained by measuring the RR interval in an ECG recording. With this information, we are able to monitor exercise intensity. The heart gives a timeline of the improvement in fitness. Maximal oxygen consumption. An assessment of maximal oxygen consumption is a way of quantifying the functional capacity of the whole cardiovascular system. VO2 max is considered the most important variable when describing the individual's fitness level. This is measured using an open circuit indirect spirometer. Blood pressure. This is measured by an intra-arterial transducer. A common technique is using a sphygmometer. This will monitor the systolic and diastolic pressure. Blood pressure is to monitor the level of change. The next part of the discussion will be on retrogression, plateau, and reversibility. Often in a training environment, individuals fail to improve or exhibit high levels of performance. This could be due to physiological decrement or digression, despite the improvement in their training programs. When things like this occur, it is highly important to pinpoint signs of overtraining. The change in training or the inclusion of easier days is allowed. However, keep in mind that a reduction in frequent training does not always lead to detraining. It may actually enhance performance. In comparison, if training is discontinued for a length of time, detraining would definitely occur. This principle is also referred to as a reversibility concept. This takes place on a training program is stepped or significantly reduced. Our body systems readjust to this change or decrease physiological stimulation. Volumes of VO2 max decrease quickly during only a month in training, followed by a slower rate of decline during the second and third months. Detraining in the cardiovascular system. Consequences of detraining are dependent on many factors. These include an individual's training status and the extent of the inactivity, whether that be decreased or completely stopped. The effect of physiological reversals will also depend on how long detraining continues. Another complication that could impact detraining is the normal rate of aging. It is often not possible to distinguish effects between aging or detraining in the elderly population. This part of our discussion will be on the influence of sex and age on cardiovascular training adaptation. The pattern of cardiovascular responses to aerobic exercise is very similar for both sexes, although the level of response may vary for some variables. Many differences in the cardiovascular responses between both sexes are related to the difference in body size and structure. Females have a higher cardiac output and heart rate, However, they have lower stroke volume than the males during submaximal exercise. Therefore, within training/exercise, a general female athlete will achieve lower scores to a general male athlete. The pattern of cardiovascular responses to aerobic exercise is very similar for both adults and children, although the level of response may vary for some variables. The values of children are often higher or lower than those of adults, but the overall direction and degree of change is similar across the age range. Differences caused by this are a change in body size, structure, and maturity. Post-training. Central cardiovascular adaptations occur in the heart that increase the ability to deliver oxygen. Peripheral cardiovascular adaptations occur in the vasculature or muscles that increase the ability to extract oxygen. Over time, these adaptations will increase the endurance capability of the heart. The heart's muscle, with exercise/training over a long period of time, will increase in size and strength. This is due to continued activity and an increase in the number of capillaries in the muscle. Cardiac output will increase from a greater volume of blood via a higher production of red blood cells. Lower resting heart rates will occur with quicker recovery rate. This is due to the adaptations mentioned above. This is also a reduced risk of heart disease.
Thank you for listening to our presentation. I hope you enjoyed it.
The following enjoyable video is a summary of our whole PowerPoint slide. Enjoy.
Let's start with atrium right. Carbon dioxide is high. Blood goes down to ventricle, pumping this blood to the lungs. Oxygen from blood. Onto the left atrium. All this blood has oxygen, moving in right from the lungs. Down to ventricle it pumps. Aorta sends out blood. Purpose relax, filling up with blood. It's in your heart. Atrium contract, feel the ventricles contract too. Come on now. Group of cells makes heart contract. Pacemakers that call it back. Gets it forward just in range. Oxygen your body needs. The heart beating. Exercise faster heartbeat. Heart muscles relax, filling up with blood. It's in your heart. Atrium contract, feel the ventricles contract too.